Postpartum hemorrhage. It is defined as blood loss more than 500 ml after normal vaginal delivery. After caesarean section, blood loss more than 1000 ml is termed as postpartum hemorrhage. New definition according to ACOG denotes blood loss more than 1000 ml irrespective of mode of delivery as PPH. Now, any blood loss causing signs and symptoms of hypovolemia is termed as PPH. Now, after 500 to 1000 ml blood loss, that is 10 to 15% of blood volume, systolic BP rises above more than 90 mmHg. There is mild increase in heart rate, lightheadedness, and palpitations are seen. After 1000 to 1500 ml blood loss, that is 15 to 25% of the blood volume, systolic BP is around 80 to 90 mmHg, heart rate is around 100 to 120, and respiratory rate increases. Now, after 1500 to 2000 ml blood loss, that is 25 to 30% of the blood volume, systolic BP is around 70 to 80 mmHg. There is oliguria, heart rate is around 120 to 140, and cool clammy skin is felt. Now a term called shock index. It is heart rate upon systolic BP. Normal range is around 0.5 to 0.7. If the shock index is more than 0.9, there is increased risk of mortality. Now PPH is one of the leading causes of maternal mortality. PPH can be primary or secondary. Primary PPH is most common. It occurs within 24 hours of delivery. Secondary PPH occurs after 24 hours and up to 12 weeks postpartum. Now, third stage of labor. It is the stage of placental expulsion after delivery of baby. Average duration of third stage of labor is 15 to 20 minutes, and if the duration is more than 30 minutes, it is called as prolonged. Now, there is a term called active management of third stage of labor. This is done for all laboring women, and this is the prophylaxis for PPH, and it helps in preventing the PPH. Now, there are some signs and symptoms of physiological separation. There will be gush of blood post-delivery, suprapubic bulge will be felt, lengthening of umbilical cord will be seen. This can be apparent and permanent lengthening. Fundal height will increase. Now we will read about AMTSL, that is active management of third stage of labor. According to WHO, there are several components of this. First and the most important component, we have to give uterotonic agent immediately within 1 minute after delivery of baby. Now, alternative, we can also give it at the time of delivery of anterior shoulder. Now, regarding uterotonic agents, the drug of choice is oxytocin 10 international units. We can give it along intramuscular route or IV route. IV route is preferred because IV infusion is faster and immediate action occurs. But no IV bolus is given because it causes hypotension and later it can cause tachycardia, arrhythmia, and cardiac arrest. The intramuscular route has onset of action around 3 minutes. The mechanism of action of oxytocin is it increases intracellular calcium and release PGF from the decidua. Now, oxytocin is produced at the paraventricular nucleus of hypothalamus. It is released from posterior pituitary in pulsatile manner. The natural oxytocin is a nonapeptide. T-half is around 3 minutes. The vial of oxytocin is ideally stored in refrigerator around 2 to 8 degrees Celsius. This is also known as milk ejection hormone. Now there are some other drugs for active management of third stage of labor. One of them is methergine, also known as methyl ergometrine. 0.2 mg intramuscular dose is given. This is kept in a brown colored ampoule because it is photosensitive. Methergine causes tetanic uterine contractions, where contraction it causes tetanic uterine contraction. Now by oxytocin, contraction is followed by relaxation, but in tetany there is no phase of relaxation. Methergine acts more on the lower uterine segment, but oxytocin acts on both upper and lower uterine segment. Side effect of methergine is severe transient hypertension. Contraindication are heart disease, vascular disease, and preeclampsia or eclampsia. Relative contraindication is Rh negative pregnancy, and it is contraindicated after delivery of first twin. Another drug is sintometrine. It is a premixed combination of 5-unit oxytocin and 0.5 mg methergine. It is more potent but not easily available and expensive too. Another drug is carbetocin. It is a synthetic oxytocin analog. It is an octapeptide and T-half is around 40 minutes. The dose is 100 mg slow IV over 1 minute. Another drug is injection Trenexa. This is given 1 gram IV infusion over 20 minutes. If given faster, it can cause hypotension. In high-risk patient, we can give injection Trenexa plus oxytocin. Misoprostol is also one drug. This is a PGE1 analog. Dose is 600 microgram oral. For prophylaxis, we give 400 to 600 microgram. It can be given in asthmatic patients. Side effects of misoprostol are hyperthermia, fever plus chills occur, and this is dose related. Another side effects are hypotension, nausea and vomiting. Now note, there is one drug carboprost, which is PGF2 alpha and a methyl analog. This is used in treatment of PPH but not in the treatment of active management of third stage of labor. And also note that by giving uterotonic agent, PPH risk is reduced by 50%. Now another step in management of AMTSL, we have to deliver the placenta by controlled cord traction. Now controlled cord traction is done by two steps. First step is pulling the cord down, and along with it we have to keep pushing the fundus up. Pulling cord down and pushing the fundus up. By this we are applying counter traction. And what will happen if counter traction is not given? Inversion of uterus can occur. Now this is known as modified Brandt-Andrews method, and this can be done only when the trained birth attendant is available. Another step is delayed cord clamping. This is a universal guideline. Delay of more than 1 minute should be done for cord clamping. If within 1 minute the cord clamping is done, this is known as early cord clamping, and it can lead to anemia. Now delayed cord clamping is done after 1 minute. Due to this step, extra 80 ml blood goes to the fetus, which is 50 mg of elemental iron. In HIV cases, we have to do delayed cord clamping, and in HIV we have to focus on antiretroviral therapy. There are some indications of early cord clamping. This has to be done if baby needs resuscitation, Rh negative fetus with ICT negative, and baby is known case of heart disease. In these cases we will do early cord clamping. Another step is there is no indication for routine uterine massage. We just have to do intermittent uterine tone assessment. We have to do it every 15 minutes for first 2 hours. Now we have read all the steps of AMTSL. So among the 4 options, which of the following is not a component of AMTSL? It will be early cord clamping. Now there are some risk factors for postpartum hemorrhage. First is over distension of uterus. This can be due to polyhydramnios, twin pregnancy, or macrosomia. Another risk factor is prolonged labor, induced labor or augmentation of labor, instrumental delivery, antepartum hemorrhage, that is placenta previa or abruption. If there is any previous history of postpartum hemorrhage or previous history of retained placenta, diabetes mellitus, preeclampsia, multiparity, use of tocolytics, that is MgSO4, chorioamnionitis, fibroid uterus, obesity, placenta accreta spectrum, anemia. Now we will move to pathogenesis of postpartum hemorrhage. Now there can be 4 mechanisms of blood loss. We can remember it by 4 T's. The 4 T are: most common, decreased tone. Atonicity is the most common cause of primary PPH. Another T is trauma to the genital tract. Next T is tissue. Retained placental tissue is the most common cause of secondary PPH. Retained placenta causes primary PPH. And the last T is thrombosis, that is defective coagulation. Any coagulation disorder, platelet dysfunction, or DIC, consumptive coagulopathy. Now we will move to management of PPH. Now PPH is an obstetric emergency. First step is call for help. Then we will go by ABC protocol. We have to give oxygen by mask, monitor vitals of the patient, insert 2 large bore IV cannula, 14 or 16 gauge, that are orange or grey. Simultaneously we have to send for investigations, that is CBC, blood group, RH, coagulation profile. Plus we have to do resuscitation with crystalloids, NS or ringer lactate. Twice the blood volume lost is replaced. Massive transfusion we have to give, arrange blood and blood products, plus catheterize the bladder.